So we are going on to the second session, and the main theme of the second session is actually breathlessness, which is again a very common symptom that we all see in our practice. So the first presenter, the first case will be presented by Dr. Bala.
My name is Bala. I'm from SJMC. So in the second part of this morning session, we are going to talk about a common symptom. A patient sees you with complaints of breathlessness. What do you mean by breathlessness? He says, doctor, when I walk 5 feet, I become more breathless. I cannot breathe. I feel I have to rest. Or he says, yesterday I could walk about 20 feet. Today I'm more breathless than before. So this is one of the symptoms that you would face in your practice. So we are going to discuss various aspects of breathlessness in this part. Okay, breathlessness as a symptom. This is what we are going to look at, all right? Various presentations of breathlessness. My one will be a straightforward case, not straightforward really, but presentation of breathlessness in heart failure with reduced ejection fraction. So as you know, all of us have guidelines in managing patients with reduced ejection fraction, with preserved ejection fraction, and patients who present with breathlessness. What are the modalities of presentation and what is the treatment modalities? So we're going to implement optimal guideline-directed medical therapy. That is what we are all here for, to implement guideline medical therapy. And we will never go wrong if we follow the guidelines. So my patient, we start with my patient. He's Mr. R. He's 38 years old. He presented with chest pain. Remember the dates, huh? Just look at the dates. He presented on the 9th of December at 10 o'clock. His chest pain started the day before, on the 8th of 12. But he just took a trip to Malacca because he's a lorry driver. He came back the next day, he still had chest pain, 7/10, and then he came to our center. His symptoms were associated with shortness of breath and palpitations. His first presentation, no medical history, he was not on medication. He does not smoke. So you see, he's practically got no risk factors. So what's he doing here? He works as a truck driver. Physical examination, I would like to stress that his BMI is 35, yeah? He's alert, he's not cyanosis, but he's breathless. He requires oxygen, nasal oxygen, 2 liters per minute. His vital signs, his blood pressure is very good. His heart rate, he's a bit tachycardic. His respiratory rate is a bit fast. His temperature is 37, prominent neck veins. Precordium, he's got a gallop rhythm. Okay, always have a full examination of these type of patients. And he has lungs, crackles over the lower lungs bilaterally. Abdomen is soft, no organs felt, and no ascites. But he has got bilateral pleural effusion. So this gentleman has got features which suggest that he's in cardiac failure. All right? What are the things you would do for him?
I think the question is there on top. Dr. Choi, would you like to interpret this ECG?
So the first thing, ECG was done, all right?
Yeah. So in the patient with the clinical features suggestive of a heart failure, when I approach the ECG, let's just look at it. So it's a 12-lead ECG, sinus rhythm, not tachycardic. The prominent features will be the ST changes on this ECG. Evidently V1, obviously from V1, V2, V3, V4, V5, and maybe AVL and AV and lead 1 as well. Yeah. So it's extensive anterior to lateral ST elevation, and together with a little bit of a Q from V1 to V2 to indicate that probably it has been a bit of a progression already. Now, when I look at this ECG, I think it's quite sensible to say that some kind of a STEMI is going on. Whether it's acute STEMI or it's a slightly delayed STEMI, we are not too sure. Because sometimes when you have overt ST elevation over the anterior leads, this could also represent some form of aneurysmal changes as well. That's my take on this ECG.
Yeah, so at this point, you see that he's a bit tachycardic, about 100 per minute. And the classical ST elevations over the anterior leads, in fact, this tombstone sign like that. But he's got already Q waves. Remember, he presented 2 days after his infarct, after his onset of chest pain. So you would think that, well, this chap has got probably a transmural infarct, and he's already 2 days. So what would you do for him? So here you have a gentleman presenting with features of heart failure and etiology, coronary artery disease.
Okay, so we've established the fact that the patient is actually suffering from a myocardial infarction, right? It could have happened like more than 24 hours. Whatever it is, the mainstay of treatment here, first of all, is to administer antiplatelets, preferably dual antiplatelets, right? That whatever drug you want to give is up to individual choice. Usually we use aspirin, Brilinta, or even Plavix. And secondly, the patient is also in heart failure, right?
Yeah, he's in heart failure.
Yeah, so
He's in CLIPS too.
correct. So we probably have to administer some IV diuretics, right? That will get him out of failure. And he will need some form of reperfusion therapy. Now, that depends on his clinical condition. So if he has no ongoing chest pain and he's in heart failure, you probably have to get him out of heart failure first. And then later on, he will need an angiogram, what we call a pharmacoinvasive therapy, right? Or if he's still having ongoing chest pain, if it's more than 24 hours, then you may have to take him for an immediate angiogram as well. And other things, probably also start him on a statin.
I think you have answered Dr. Kaur's questions also. But Kaur, give your opinion, please.
Yep. So the diagnosis is clearly the etiology is a myocardial infarction. So the question is whether there's still viable muscles there.
Yeah.
And in a young patient, if the reperfusion probably is not the issue. It's just the timing when you're going to reperfuse the patient. Two scenarios. If the patient is still having chest pain ongoing, means that there probably is a substantial myocardial viability there, because you can see that the lateral lead also elevated without much Q wave. That denotes that the stenosis is probably at the very proximal part of the LAD, and probably the infarct in the distal part established. Yes, you can see the Q wave, but the proximal part probably is still viable. Now, however, if the patient has no more chest pain, you still have to remember that in a person that's 3R3, how do you know that there's no RCA stenosis or circumflex stenosis? You still need to reperfuse that, even though the LAD is infarct. It's just that the timing, probably a bit later, when the patient is more stabilized out of heart failure.
So here you have a patient who has an established infarct. He's got Q waves in the anterior leads. But remember, he's still having chest pain. So as Kaur says, his myocardium definitely is viable, and you must do something about it. You can always opt for just conservative treatment, optimize heart failure treatment, and then later go in. But here you have a man who's having chest pain. Let's see his biochemical markers.
What if you are in a hospital without PCI?
So we have already discussed that most people will do a coronary angiogram at some point, all about timing. But if a hospital does not have facilities for coronary angiogram, then we will treat medically first, anticoagulation.
I think the specific question would you give thrombolytics?
Yeah, it depends on whether it's early or late.
This
Yeah.
man,
So
this man.
It's 2 days already. So
because
he
it's
has already
now
gone
late.
beyond the 12-hour
Yeah.
period. So you would think of referring to a center with facilities as early as possible, isn't it?
Yeah, but we are now late, so we can't thrombolyze. I think it's too late for thrombolysis.
No, you can't. Usually, if you anticipate that you can do a PCI within 120 minutes and you are in a facility without PCI, if you can transport him within 120 minutes to a PCI facility hospital, then you can send him straight. If you feel that you cannot do it within 120 minutes, then you're justified to start him on thrombolytic therapy and then refer him. So pharmacoinvasive therapy. You start with the drug, thrombolytic, and then you move him to a PCI facility hospital. That is if he presents within 12 hours. Some of his blood investigations. So you have done his ECG, you have established a recent infarct, anterior wall infarct. What are the blood investigations? It looks quite okay. Look at his pro-BNP and the TROP-T, grossly elevated. All right? And at this juncture, CKMB is also elevated, in addition to the other markers. So, Dr. Choi, what blood test shows? Blood test shows an established MI. What is the risk of ventricular rupture? I think, no, you wouldn't consider thrombolytic here.
No, let's assume that you are somewhere and somebody decides you want to give thrombolytics because he's still having chest pain. You cannot give a thrombolytic. Would you give? And is there a danger of ventricular rupture if you had given thrombolytics?
Yeah, I guess, some centers without PCI facilities, one would probably think, oh, logically, why don't you just give and wait and see, benefit of the doubt. Well, it's not like what Dr. Jay mentioned, it's not without danger, not to mention the bleeding risk involved. In a patient, I think anecdotally, elderly patients, female patients, if they have established MI, maybe with a bit of a thin wall myocardium already, if you administer thrombolysis, a thrombolytic agent, there's a small degree of a higher chance of ventricular rupture. So when you have a ventricular rupture, and depends on where it ruptures into, of course, it's a free wall rupture, it can be quite deadly. So I think that would be something we should consider.
I think that's why people say it's an umbrella of 12 hours, which
Correct.
is what Dato has been pointing out.
So, okay, we move on to, that's just an interesting point. So when you see a patient with established infarct, more than 12 hours, think of other modalities, yeah? Cholesterols, lipid profile, cholesterols, total 5.7, HDL 0.98, pretty good, huh? LDL is 3.2, but look at this HbA1c, 13.4. So here we have a man who's got mildly elevated cholesterol levels, but a newly diagnosed diabetic. So this is the risk score, and he's also obese, okay?
Are you surprised this young man develops an MI considering he is a non-smoker and his lipids are not high? Yeah. Well, I mean, you look at his other risk factors.
Yes,
He's
that's
obviously
right. Yeah,
diabetic.
yeah.
He's obese.
Obese.
There was no mention about family history of premature coronary artery disease.
Yeah.
So we assume probably not.
No,
But
there was no family history, but there was a doctor who asked just now about stress. He's a truck driver.
yeah, so that's probably a contributing factor. And so I'm not really surprised. And even if you look at our local NCVD ACS registry, the mean LDL levels of males you see who are presenting with an acute coronary event is about 3.1. So not surprising.
So even then, its LDL is 3.4, but you know that a patient who has got established coronary artery disease, risk factors of diabetes, obesity, you would love to bring his LDL to 1.4 at least, right? Not so high. So it is elevated. So this is the chest X-ray. It's an AP sitting, so don't talk about the heart size. It's upper lobe diversion of vessels, interstitial edema, curly B lines, no pleural effusion. So he is in CLIP 2 at least, all right? So we took him in for angiogram. We had to because he had ongoing chest pain. His heart failure was mild. So we took him in. It's the left main artery. This is a spider view, the left main artery. This is the LAD going up here. This is a circumflex artery. So you can see the LAD is totally occluded. Left anterior descending is totally occluded. We aspirated a lot of thrombus, and we opened up the the vessel very easily and deployed a stent from the ostium to the proximal segment. It's about 28 mm long, and we established the flow to that territory which was infarcted. Knowing fully well that area you have Q waves already, it's probably infarcted. But he had chest pain, so you give him the benefit of the doubt. So that's why we revascularized him. The echo, this is a 4-chamber view in a normal person. You will see that this is LV, this is LA, right side, right ventricle, right atrium. And in comparison with what he has, is a totally dilated ventricle. It's about 6 to 7 centimeters, millimeters. And the EF is only about 25%. Okay? So it's a totally dilated left ventricle. So now you're dealing with a recent anterior wall infarct, post-PCI to the LAD, congestive cardiac failure with reduced EF, ejection fraction 25%. Right? Remember, our usual ejection fractions are about 55 to 75. Here is about 25% in CLIP2, new onset diabetes, dyslipidemia, and obesity. So all his risk factors are all here. Right. Okay, go
Dr.
ahead.
Koh, how would you now treat this patient?
All right. So once we have addressed the etiology of the heart failure, which is you've done a very good job establishing the flow for the coronaries, now we have to treat the condition. Now the condition now is in congestive cardiac failure. No doubt that initiating all the heart failure medication are very important, but the limiting factor is always the pulmonary congestion as well as the blood pressure. A lot of time they have low blood pressure to begin with initially, and then improve slowly. So there are 4 types of disease, or I would say prognostic modifying heart failure therapy, mainly the beta blockers, the SGLT2 inhibitors, the renin-angiotensin systemic blockers, and also the mineral corticoid, MRA, the mineral corticoid receptor blocker. The MRA probably the one that you can start almost immediately, 24 to 48 hours, because they don't drop the blood pressure, and it also acts like a diuretics. So these are the classical spironolactone or newer generations such as eplerenone. And once the blood pressure is, you think is more than 100 systemic mmHg, then perhaps ACE inhibitors or angiotensin receptor blocker, or even the newer generation, the ARNI, angiotensin neprilysin, receptor inhibitor,
that's right.
can
ARNI.
be initiated within 48 hours, as long as the blood pressure is okay. But the trick is to always start in the lowest dose possible and titrate up. You can always titrate up if the patient is okay. Now for beta blockers, if the patient is a de novo heart failure and de novo to beta blocker, means that patient never had a beta blocker before, it's always better to start when it's out of heart failure, means that the lung is decongested, lung is clear. Then it start a very low dose as well. Because if you initiate too early, it will actually decompensate the heart failure better. Now, for some reason, with some patient already on long-term beta blocker, so the recommendation is not to withhold the beta blocker. Sometimes I tend to cut down a bit the beta blocker dose, but I don't stop the beta blocker unless the blood pressure is very, very low. So then SGLT2, the new kids on the block that has been shown to improve in a very impressive manner, but these are usually done in my patient usually in a stable condition, no urgency to start that. Maybe perhaps after stabilized before discharge, then we initiate that. Remember that the SGLT2 also promotes a bit of diuresis, so sometimes you have to watch the input-output of the patient and adjust the dose of diuretics for this group of patients. So now these are the 4 prognostic modifying drugs that should be administered as early as possible in any patient with heart failure.
So thank you, Tuko. So we have these patients, these 4 pillars of heart failure. So follow the guidelines, 4 pillars of treatment modalities in patients with reduced EF. All right, but you also must look into his blood pressure, his heart rate, his potassium levels. Remember, you want to start spironolactone, potassium levels. You have to look at his EGFR also. Anything less than 20, you can't give drugs like SGLT2 inhibitors. So you have the basic biochemical markers, then you also initiate your treatment. Don't blindly go into the 4 pillars. You just have to look at the patient on its own merits. Dr. Yap, when would you start anti-lipid therapy?
So in acute coronary syndrome, So this patient is a post-MI. The answer is as early as possible. We need to be aggressive with the lipid lowering using a high-intensity statin. So before the patient is allowed his next meal, he should have a statin already.
Yeah. So this chap had a LDL of 3.4. So he's got established coronary artery disease. He's got risk factors. His LDL should come down to less than 1.4. Follow the guidelines. It's very simple. So you start high, you monitor his lipid profile, but that's where teamwork works. You know, teamwork. That means the physician, the dietitian, the physiotherapist, the nutritionist, all these people work together to help this gentleman. All right. So what did we start with in this patient? We started with his usual antiplatelets, cardiopirine, ticagrelor, because he's got a long stent, a 28 millimeter stent. So he's in KLIP 2. So offload his heart, offload his lungs. IV Lasix, all right? It's a basic thing, IV Lasix to offload him. You are lucky because his blood pressure is still good, 135/80. So you can start valsartan. His heart rate is about 90 when he first came in. So bisoprolol, but don't go overboard, okay? Start low as co-was start low, start slow, but incorporate all the modalities of heart failure treatment. All right? Luckily, he's also a diabetic in the sense that you can start empagliflozin maximum 25 milligram. Usually you start at 10 milligram. And this lipidemia, as Dr. Yap says, hit him hard, bring it low. So he's on Atozet, which is a combination of atorvastatin and ezetimibe, 1040 combination. This is not the end and all. It's when we start with this treatment. But as we go along, we optimize. Okay? Don't forget these aspects also. Huh? When you treat a patient with recent infarct, obese, diabetic, this in heart failure, EF 25%. So non-pharmacological treatment. So these are the other aspects of medical treatment that when you incorporate the help of the heart failure team, which have the pharmacist, the dietitian, the physiotherapist, right? All these people come into play. And also don't forget the family members. Make them understand. Make them understand what heart failure is all about. What are the difficulties he will face? What are the challenges he will face? So these are the things. Just so always include the family members in your discussion. All right. If we progress, patient recovered after 5 days and was planned for discharge. But you just don't discharge him just like that. You have initiated and uptitrated the Entresto, the Arni group of drugs, which is a combination of sacubitril and valsartan. You start a low dose, maybe 50 on morning, then you can increase. If BP allows, you can go up to 200 PD. Beta blocker, MRA, spironolactone, based on blood pressure, heart rate, serum potassium, and renal function. Please remember these investigations when you start any treatment. Blood pressure, heart rate, serum potassium, and renal function. Okay? That is when you get your help with your friends. Collaborate with a general practitioner, primary care provider to adjust hyperlipidemia, because you're not going to see this patient every day. You're going to see him in 2 weeks' time to see how he has progressed. You're going to see him in 1 month, 3 months. When he's quite comfortable, you're going to send him to his physician, his private practitioner, to look after his hyperlipidemia and diabetic medication, and to go according to guideline recommended goals. Okay? Always use the guidelines. This is the guideline which is available. All right? Please have a look at this. All right? Here we talk about the optimizing the management of heart failure with reduced EF, the 4 pillars, RAS blockers, MRA beta blockers, and SGLT2 inhibitors. So you start with RAS blockers. beta blockers, MRAs. After Lasix is toned down. After withdrawing the Lasix, you can start all this treatment. Always find out what is the cause. We found out in our patient the cause was coronary artery disease. We rectified that. We looked into valve disorders, there was nothing. Now this is where this comes in. What would he develop? Would he develop AF or did he present with AF? So we treat accordingly. Rate control with beta blockers, anticoagulation. And next one is ventricular arrhythmias. What is the choice of therapy here? All this to treat the underlying cause of heart failure. So this is all looked into after you have treated basically his heart condition. Okay? If the LVEF remains as less than 40 and patient is still symptomatic, okay, you would consider CRTD. If it's sinus rhythm with left bundle branch block, QRS more than 150 milliseconds. Okay, Ko will be talking about this later on. Okay, this aspect also is there in the guidelines. Iron deficiency. So sometimes the patients will have low iron levels. That's where intravenous iron therapy helps. Okay, if the LVF is less than 40 and patient is asymptomatic, so what would you do for him? If he's asymptomatic, fine, good, you're right. He will improve over time. Okay, that is as you go along. But if he's still symptomatic, you would think that he's volume overloaded, then you modify your treatment accordingly. Where Risiquat is not available here is a 10 milligram tablets to add on to your therapy. Okay, advanced heart failure, consider heart transplant, LVAD as a bridge to transplant, and palliative care. So we continue maximally tolerated doses, reduce the diuretics, optimize dosing and patient adherence, and cardiac rehab. All these aspects are very important in managing this patient after he had had his coronary event. So what is non-pharmacological measures? That is educate the patient and the family about the disease. Treatment options, whether you need a device therapy, whether you continue with your medication. All right, all this is with encourage lifestyle measures, proper balanced diet, weight management. Right, our patient had 31 BMI, so he should come down to the ideal 23 to 26. Regular physical activity, smoking cessation. Okay, fluid intake is very important. A lot of patients cheat a lot. Okay, it will never be maintained 1 to 1.5. So stress that factor that if you drink too much, you will be paying for it with problems of breathing. All right. Provide advice regarding sexual activities, pregnancy, address psychosocial problems encountered by the patient and the family. So always include the family in your discussion. It's very important because a lot of these patients cannot bear the cost of treatment. So you must adjust to the treatment modalities according to the economic status of the patient. Okay? I think that's about all.
There's just one last question. Can we see the next slide? This is, I think, to you. Okay, 1 week later, this patient comes to see his GP. Okay, and the his GP notes his BP is 95/70.
Okay.
GP calls you. Okay, Dr. Bala, what do I do?
So,
Remember, you have sent him home with ANI la, beta
First of
blocker
all,
la, everything.
First of all, thank the GP for referring back to you. And remember, his BP is 95/70. If it's more than 90, it's okay, systolic. All right? Don't go and drastically reduce the blood pressure medicine. 95, his peripheries are warm, he's alert, he's okay, fine. Now the fever, look out for fever. Usually 1 week after coming from the hospital is thrombophlebitis. The venophic sites are all swollen, and you just investigate for the fever. I mean, that
Yeah.
part is easy, but just don't alter the medication at
Yeah,
this stage.
that is the stress. Don't alter. These medicines are given for heart failure, not for blood pressure. Patients comes and tells you, BP is 95. Do I need to continue my RAS blocker or my beta blocker? No, it's given for heart failure, not for blood pressure. Okay, this is very, very important. Okay, thank you very much, Dr. Bala. I think we'll move on to the next. I think Dr. Koh is going to present the next case.
Okay, good morning again. I'm Kok Wei. I'm actually more of an electrician. So this morning and just now, Dr. Bala, we have discussed a lot of plumbing issue, all these arteries. So now I'm going to fix the wiring in the heart. Let's go through the first case. Okay, I have this patient, 41-year-old man, presented with palpitation, which he described as almost continuous for the past 1 week. And then later on, cannot tahan lah, they said. Come into my clinic, abdominal is I have this bloating sensation. Walked from the lift to my clinic already panting. Chest discomfort. But there's no history of cough, there's no history of fever. Interestingly, he has history of SVT ablation done about 2 years ago. Now, physical examination, the blood pressure is stable, the heart rate is elevated with frequent misbeat. Now, JVP is not raised, but on the lung, auscultation of the lung revealed fine bibasal crepitations. A bit of Gallop rhythm there, maybe because of the misbeat. No murmur, abdominal soft, no ascites, no pedal edema. So, I will have to ask the question myself. Is this patient in cardiac failure? Now, heart failure is a clinical diagnosis. If you have someone that has presented with breathlessness on effort or at rest, if he has any peripheral signs of congestion, for example, lung congestion or systemic congestion, pedal edema, raised JVP, ascites, then he is already in heart failure, all right? And if it doesn't have this sign, then maybe sometimes you may want to order biomarkers like pro-BNP. So you have symptoms or sign, then it's already a heart failure. If you think that the sign is very subtle or no sign at all, then you order biomarkers, is positive, pro-BNP is raised, then it's already in heart failure. Right. So the next question to Choi, what do you think that he
Was
has?
your patient in heart failure?
Yeah, my patient is in heart failure because clinically it's heart failure, so I don't even order a pro-BNP for this patient.
You have a patient with heart failure, history
Yep.
of ablation for an
Yep.
arrhythmia.
Yep.
I guess the question is to relate the abdominal bloatedness to the heart. I guess my understanding is if the patient is congested, sometimes it may be translated into some kind of a symptom other than the heart. Abdominal bloatedness may be a sign of liver congestion. Or, on the other hand, if whatever thing that caused him to be in heart failure, for example, arrhythmia, may be the presenting symptom, presenting reason why he has abdominal bloatedness as well. Give an example, if the patient has PVCs to begin with, for example, some PVCs may present itself rather than having misbeats. They may have GI discomfort, abdominal pain, could be a trigger for the ectopics itself. So I don't know. I think this could be one of the reasons.
I agree. I see a lot of patients coming with ectopics. They have actually bloating. So after tackling or treating the arrhythmia, sometimes the bloating goes away. And these certain arrhythmias like even paroxysmal SVT, arrhythmia, like atrial fibrillations, they sometimes causing the patient also develop reflux symptoms, dyspepsia. These are called the gastrocardiac syndrome. And sometimes you have to treat both as well. Because remember, the esophagus is behind the heart. They are closely related, in fact, touching each other. When we ablate atrial fibrillation, sometimes we are afraid of causing ulcers to the esophagus. All right. So ECG was done. So this was probably about 1.5 years ago. So the ECG here is a bit blur, but I hope everyone can have a look. In the ECG, what you can see is there is a narrow complex. Then there's another one, is a bit broader complex. Whenever you see a broad complex in the ECG, always think of coming from the ventricular origin. Anything that is narrow, definitely coming from the supraventricular, which is the atrial origin. Now, if you then you look at the broad complex, I'm not too sure whether you can see it clearly here, but what I want to show you that there is no P wave before the broad complex. So it means that this is definitely a ventricular origin. If you see a P wave before the white complex, then this may be premature atrial beat with aberrancy. Aberrancy means that it's conducted in the left bundle or right bundle fashion. But again, broad complex is almost always a ventricular origin. So this patient actually has bigeminy premature ventricular complex or PVC. You can see that. Let's explain the misbeat. So initial investigation, the usual one, we will just make sure everything is okay, especially the, what do you call that, the FBC, renal function. All these are actually one set, so I just send everything. And the X-ray and echocardiogram will probably show you interesting features. The X-ray shows the classical bilateral diffuse interstitial opacity and some septal lines there at both lower zone and the upper low pulmonary diversion there. So these are congestive heart failure sign in the X-ray. The heart also appeared slightly enlarged, but I think this is an AP projection. You can see that the heart, on the left side is the parasternal long axis view, and the left side is the short axis view. It hardly contracts. So it's very hypokinetic globally. And noted during the echo, you also can see that there's a lot of PVC couplets. Now then I look back at the previous history. In the previous history, these are Holter's finding. You can see that previous history when he presented with the SVT, it is indeed the SVT because electrophysiology study have done. The Holter also shows that the narrow complex tachycardia. And surprisingly, there's also infrequent premature ventricular complexes even at that time. So now we know that this patient does have a SVT that's ablated, but at the same time, he also have a bit of infrequent PVC at that time, which we do nothing about it because after the SVT ablation, he remained well without any symptoms. So now I have a luxury of knowing the background history of the patient. The echocardiogram previously before the ablation was normal to begin with, and now the patient is having a heart failure with increasingly more PVC. Now, the diagnosis at this point of time, in a young patient, my provisional diagnosis would be arrhythmia-induced cardiomyopathy. So now what do I do with this patient? I admit to the CCU, and in the CCU, suddenly the nurse called me with this rhythm. So in this rhythm, this is more clear that from behind, I think you can see that there's a narrow complex followed by a runs of broad complex. So again, the broad complex. Now, this is a bit more tachy because it is very fast. The RR interval is very short. So my question to you all is this a ventricular rhythm or a supraventricular rhythm? Ventricular rhythm, raise out your hand. Or at least 5 of you are correct, 10 of you is correct. So again, I have to emphasize, if you see a broad complex, bet your money on ventricular rhythm because that's a more common one, okay? Bet your money on the ventricular rhythm. Okay. All right, so I'll admit to the CCU patient, started on amiodarone infusion, magnesium infusion, give Lasik to decongest the heart failure. I start a bit of beta blocker because I want to control actually the arrhythmia, the ventricular tachycardia.
So Choi, why do you give IV magnesium?
So in this patient, IV magnesium sulfate was given. My perception on magnesium sulfate is like it's like stabilizer, a peacekeeper. So any arrhythmia, especially ventricular arrhythmia, when you give magnesium sulfate, it calms the heart down. A very good example will be like polymorphic ventricular tachycardia. How it works, I'm not really sure, but I think it has a bit of a anti-calcium effect. So it will slow down whatever ventricular ectopics you see on the patient, and most of the time it will calm the heart down a lot more than before.
Yeah, I agree that. So magnesium sulfate is most useful, especially the patient has torsade de poids, which means the polymorphic VT. Magnesium is frequently depleted in any patient in acute setting, heart failure, even in infection. We always check, especially got arrhythmia, they're always down to at least 0.6 and below. So they're always in a very low level. And once it happens, then the heart becomes destabilized because magnesium are required in many of the transporter in the cardiac function. Now, the second question, what about IV calcium? So before this, one have to understand most of the ventricular ectopics, the mechanism behind ventricular ectopic actually is intracellular calcium overload. So most of the time, if we want to ablate a patient with a ventricular ectopics, we cannot induce with other method. We actually give IV calcium. Sometimes it makes the PVC of ventricular worse. So IV calcium definitely probably not for this case, especially this type of ventricular tachycardia is due to calcium overload. Now, so we have to do something because the patient keep on having this short run of ventricular tachycardia. God knows when he's going to go into ventricular fibrillation. So a bit stressed out now. We have to do something more urgently. What if this patient actually have coronary disease? Because the first thing, Dr. Bala showed a very young patient also, 38 years old, has heart attack. This one is 40, so why can't the patient have coronary disease? Of course, the first thing when the EF is very poor, make sure it's not related to coronaries, especially ischemia. But of course, the angiogram is normal. And we have to go in because the patient keep on having this VT, cannot control with even IV amiodarone. Now, how do we do a EP study and radiofrequency ablation? On the right panel, you can see a fluoroscopy picture of a single catheter. This is how we do a ventricular ablation maybe 10 years ago. We just single catheter. From the ECG, we have to imagine where is the site of origin of the ventricular ectopic. Then put a catheter there. We have to go there, try and error to see where is the focus. So it takes very long time. That is why previously when we do radiofrequency ablation, just using the fluoroscopy method, it takes like 4 hours, 6 hours. Nowadays, we have technology that allow us to pinpoint where is the location of the arrhythmia. For example, on the left panel, you can see a live mode of a 3D mapping of the arrhythmia. And if I can show you the spots, here is the spots of the focus. Can you see that? It's coming out from that spot.
The red dot.
The red dot, yes, correct. So even the non-electrophysiologists will say, so easy only, now do EP. Okay, not so easy, but it's just to tell us that now easy to pinpoint and localize the location, and ablation almost always able to achieve acute success in any arrhythmias. Like for this, the ablation for VT is almost more than 90% acute success rate.
Now, basically, patients with poor LV also have a lot of ventricular ectopics. So can you give us some guide? When do you think, which is a chicken and egg? So how do you know treating the PVCs will actually improve the LV function, or is it just a coincidental that the ventricular ectopics are there?
Yeah, true indeed. In anyone who has heart failure, it is not too surprising to see PVCs in them. So for example, you do a Holter on anyone with a EF of 20%, you get like maybe 3 to 4% of PVCs. Anyway, my take is that the more morphological difference between the PVCs, the poorer the outcome is. Dr. Koh's example, I think, shows that from the EP diagram that you saw earlier, is from a single source. So single source means usually it should come up from the same place. So the PVC morphology should always look the same. That would be a good guide. So if you do a Holter and you see all monomorphic PVCs, and the burden, if not mistaken, should be roughly between 10 to 15% on the average per day, it should be quantitatively significant. So in a patient with heart failure, the PVC burden could also be even lower, like maybe 5 to 10%. I would actually advocate some form of treatment, whether medically or like what Dr. Koh did, invasively, to get rid of the PVCs. Yeah, that would be my PVC burden.
So, Ko, can you treat this patient medically?
I would say that if you have someone with a potential curative, curative therapy for the heart failure, I would say the ultimate goal is still to treat the etiology. So it means that by hook or by crook, this guy need to be ablated lah. It's just that if you are in the center, I know that a lot of centers don't have electrophysiology facilities. So what you can do now is to give more amiodarone and pray that the patient doesn't go into incessant VT and a ventricular fibrillation. Now, some people may say that, maybe I can do cardioversion, electrical cardioversion. Yes, but you must remember that the ECG strip shows paroxysmal VT. Means that it converted itself back to normal sinus rhythm and then back to ventricular tachycardia. And you can cardiovert in case of emergency, but electively, if you cardiovert, it may just go back to ventricular tachycardia, then you have to cardiovert again. So previously, we have many patients that referred to us, cardioverted almost 20 times before referring to us. So that is a bit not appropriate lah. And another way is, let's say you can't even control the ventricular tachycardia and it compromised the BP, you cardiovert, it come back again, despite amiodarone, despite IV magnesium sulfate, you can even try lignocaine, IV lignocaine, and sometimes you might need to intubate the patient under general anesthesia. It's almost similar concept than like status epilepticus when there's a lot of overwhelming adrenergic drive. You have to calm down the heart electrically by sedation and intubation. And in patient with a VT that you think that a lot of PVC triggers it, you can actually do something called an overdrive pacing also. But that also you need a center with a fluoroscopy and also a pacing wire. Then you can override, make sure the patient doesn't go into the ventricular tachycardia. So yeah, ultimately, you can treat medically and prepare to refer to any one of us here for ablation because that is potentially curable, easily treatable.
Can I just echo Dr. Koh's opinion as well? I have the analogy to probably provide. High PVC burden and heart failure is like having a treatable cause for hypertension. So for example, if I were to get whacked on my toe with a nail and someone were to measure my BP, the BP will be high. So potential treatment, of course, is actually to get rid of the pain. So I think in this example, EF is very poor and the cause is very obvious. And if we can get rid of it in a very curative manner, I think the benefit is quite overwhelming. Just my thought.
So further treatment, just very quick, no more PVCs after the ablation, transfer to normal ward. And of course, once we treat the etiology same like the first case, the etiology was MI. Now this etiology is arrhythmia-induced cardiomyopathy. We still have to treat the condition that caused by the etiology, which is the heart failure. So we have to start medication, the 4 pillars of medication, and discharge after a few days. So you can see during follow-up, the echocardiogram definitely improved. You can see the improvement, and of course, there's no more PVC in the strip, ECG strip. Now, in conclusion, ladies and gentlemen, ventricular arrhythmia can cause a lot of problem. Initially, if you see that if the PVC coming from the right side, then your heart definitely not going to synchronize one. So it causes intraventricular synchrony as well as the atrioventricular dyssynchrony. The chambers are not talking to each other. And in any high burden PVCs of more than 15%, like in this case earlier also, but the PVC was not as high as this, but you need a close follow-up, even in a normal structural heart. A lot of patients can say that there's no symptom. Yes, correct, no symptom, but warrant close follow-up. No treatment, warrant close follow-up. Same like any other disease. You cannot tell a patient that this is benign, like how we used to tell the patient 20 years ago. Because we know that all these, some of these cases can be bad. They can eventually cause contractile dysfunction, electrical remodeling, apoptosis of the myocardial cell, fibrosis, and leads to heart failure later on. And the management, we have stressed a few times now, remove the ventricular arrhythmia because that's the underlying cause, and then treating the heart failure. Now, radiofrequency ablation remains the most effective way of treating the ventricular, in fact, any arrhythmias induced cardiomyopathy. Now, further investigation like cardiac MRI may be necessary if the EF doesn't improve after treatment, because sometimes someone might ask, how do you know that this patient doesn't have a non-ischemic dilated cardiomyopathy to start off with? Especially if you see this patient the first time, let's say I don't have the previous echo, I don't know. The patient comes now with heart failure and a PVC. Can it be the chicken or the egg? Is it the heart failure causing the PVC or the PVC causing heart failure? We don't know. But in this case, history-wise tells me that most likely is arrhythmia induced because the EF was normal to begin with. Only when the burden of the PVC increased, it gets worse. All right, so I think that's my case. Thank you very much.
The next case is going to be presented by Dr. Navin. It's a more common case.
Hi, very good morning, everyone. Thank you for being here on a Sunday. So the previous two lectures were fairly technical, a lot of plumbing and electrical, things going on. So mine is a very simple case, I would say, because it's purely pharmacological. It's something that you guys as primary care physicians will be able to diagnose and actually treat, right? So my case is a case of the man with the nagging wife, right? Because I heard a member of the audience earlier saying that, it's getting a little boring, so I decided to inject some humor into our presentation. Okay. So the patient in question first visited me in October 2022, 44-year-old Chinese male, known case of hypertension, was diagnosed about 4 years ago, started on bisoprolol by a general practitioner. Self-medicating since diagnosis, so he's not seeing anyone, he's not measuring his blood pressure at home, assuming taking the medication, everything is normal, right? So he went to see a GP, complaining of tiredness, headache for about 2 weeks. And the GP noted that his BP was elevated. I don't really know what was the reading then. So he was asked to stop on his Concor and started on Telmisartan 80 mg, which the patient had not started yet at that point when he came to see me. Further history, he couldn't stand his wife's nagging, so he decided to finally see me, right? So the wife was actually an old patient of mine. She had an atrial septal defect, so she was under my follow-up during her pregnancy. So he basically underplays his symptoms. His wife is the main historian, right? So during that short session, I understood what he meant by his wife's nagging, after listening to her story. So he feels breathless at times, denies chest pain, attributes his symptoms due to a stressful work and also family issues. So he does work long hours. He says that his job is quite stressful. Family issues besides the nagging wife. He also has an autistic child, so understandably under a lot of stress. So no offense to the ladies in the audience, but I think a lot of men can relate to what I'm saying. All right, so he's a non-smoker. Doesn't consume alcohol, fairly sedentary lifestyle, no family history of hypertension, diabetes, stroke or IHD, denies consuming any traditional medication. So BMI, slightly overweight, 26. Blood pressure, manually recorded was 180 over 100. Pulse rate was 100, slightly tachycardic. Lungs were clear, CVS, no murmurs heard. Jugular venous pressure was not raised. Lungs was clear, no pedal edema.
Navin,
Right.
maybe I stop you here. Now, this young man complained of breathlessness. And he's supposed to be on bisoprolol. So do you think his symptoms are due to the bisoprolol, or from your physical examination, you think it's due to something else?
No, by the time he saw me, actually, he had even stopped the bisoprolol. Yeah. So he was not on any medication at that point in time.
So specifically, is he in heart failure?
No, he's not. I mean, like what we've described earlier, the clinical features of heart failure, lung crepitation, pedal edema, ascites, he had none of those, right? And even the JVP was not raised. Yeah, pulse rate 100. I think if the wife goes out, maybe it'll come down to 80. Okay, so what's the simple test that we can do? So again, something that can be done, in a primary care setting, blood test, urine test, ECG, and a chest X-ray, right? Okay, so his renal function was normal, eGFR was more than 90, full blood count normal, liver function test normal, lipid profile, cholesterols were elevated, total cholesterol of 6.2 and a LDL of 3.6, and there was some proteinuria, right? So not in the nephrotic range because the albumin was normal in the liver function test, but just 2+ protein. So that tells us that probably, he's been hypertensive for some time. My apologies if the ECG is not very clear, right? So I'll just comment a bit on the ECG. So this is a very classical ECG showing left ventricular hypertrophy, right? So if you look at what we call the Sokolov-Lyon criteria, right? You have deep S waves in V1 and tall R waves in V5 and V6, right?
Someone asked about the ST.
Yeah, so classically you can actually see the strain pattern in left ventricular hypertrophy where you can actually see the ST depressions in the lateral lead, right? So that's the deep S wave there and the tall R waves in V5. And also some left axis deviation there, right? So later we'll have another ECG on LVH during the session on ECGs and chest X-rays. Okay, so this is his chest X-ray. So cardiothoracic ratio is slightly increased, more than 0.5. I wouldn't say there's a lot of pulmonary congestion going on. Some may argue there's a bit of a bad swings appearance there, right? But what I'm trying to emphasize here, the heart is enlarged on the chest X-ray, right? So what did I do next? Okay, so of course in our setting, we have the luxury of doing an echocardiogram. So you can see here, this is a long axis and a short axis view, right? So you can see that the left ventricular is slightly dilated and the contractility is reduced. You can also see it in the short axis view, right? And if you look at the next slide, this is the 4-chamber view. Again, the contractility of the left ventricle is reduced and the chamber appears to be enlarged. So we did a objective measurement in the M mode. You can see the LV size, right? So above 5.9 is usually elevated. This is about 6.4. And the myocardium thickness is increased as well. For the interventricular septum, about 11 millimeters, and the posterior wall is about 14, right? So he definitely has at least mild left ventricular hypertrophy with LV dysfunction.
His LVEF is 30%. His
Yeah.
LVEF.
Yes, about 30%, right? Okay, so what's the additional blood test that I did? Because, now he seems to have heart failure, heart failure with a reduced ejection fraction. So I did a pro-BNP as a baseline. So as you can see, for his age, the pro-BNP should be less than 450 and his is about 635, right? So of course, we've seen some much higher, some can't even be measured, it's just written more than 10,000 or more than 15,000. His is not so high, but it's still elevated. Okay, so now we know we are dealing with a case of heart failure. And what is the etiology? Is it ischemic? Is it non-ischemic? A simple thing that we can do to rule out coronary artery disease is a CT coronary. He doesn't need an invasive angiogram, right? Because he doesn't have any chest pain or anything like that. And the CT coronary revealed normal coronary vessels, right? So what's next? Are we dealing with a case of hypertensive heart disease? Myocarditis, possible as the onset was fairly short, right? Or some form of infiltrative cardiomyopathy. One thing that we can probably consider is a cardiac MRI, right? But again, cause reasons and so on and so forth. So looking at the history, to me it occurred that it seems like a case of hypertensive heart disease. So I opted to treat him first and see if he doesn't improve with treatment somewhere down the line, then probably consider a cardiac MRI. Okay, so simple treatment. So that's why I mentioned it's just pharmacological treatment, right? Started off with Arni and Entresto. right? 50 BD, right? And gradually over the months, I increased it up to 200 milligrams BD, right? Started him on a SGLT, Foxiga, Furosemide, Concor, Spironolactone, and also Crestor, right?
Before you go, can I just ask you, you put in back one slide. You have got quite a number of medications there which can affect kidney function.
Yeah.
Can you tell us how you would actually follow up? I mean, you have actually seen him for quite some time. How did you follow up these patients? What were you looking for? Because there's a lot of medications.
Correct. So if a EGFR is more than 30 on presentation, they should be around the standard therapy, right? So we do start this kind of medications for those who have mild renal impairment as well. But what is most important is regular monitoring of the renal function and also the blood pressure, right? So if we see somewhere down the line, say after 1 or 2 months, his EGFR reduces by about 30%, or his potassium is persistently elevated more than 5.6, then you may consider cutting down on the dosage of some of the medications or even stopping it in certain cases, right? But otherwise, the patient should be on the standard care of therapy.
What about blood pressure?
Yeah, blood pressure is the other thing. I mean, like what I think Dato' Bala has discussed earlier, we need to monitor that as well. And the other thing is also the patient can monitor his blood pressure at home.
Naveen, can I ask you, this man doesn't seem to have much congestion on the x-rays, right? And your examination also showed not very much of classical heart failure signs. Mainly seems to be quite elevated blood pressure. Mm-hmm. If you were to just give him blood pressure treatment without diuretics, do you think that alone would be enough? And watch him bring down the blood pressure, whether his lot of symptoms will improve.
Yeah.
Now we've got these 4 pillars, but these 4 pillars don't apply for everybody, and this one looks very much like hypertension,
Correct.
hypertensive heart disease.
So the thing why I also started his Concor and Spironolactone in the beginning is because when I initially started the Entresto, I started at a lower dose, because he's not been on an ACE or ARB before. So along the way, I actually managed to reduce a lot of the medications. I actually took off the furosemide, I took off the Spironolactone, and this is the beginning when I first started him. So I agree he was not in overt heart failure, but again, like I said, he did underplay a little on his symptoms. So clinically, although he was not in failure, I also started these medications for blood pressure control. Okay, so by November, he's been under my follow-up. By November, the pro-BNP had normalized, right? And if you look at the echo, very noticeable difference, right? You can see the LV function has really improved in both the long axis and short axis, and even in the 4-chamber view. And the LV thickness has also reduced, right? And the LV size has reduced back to normal. So you can see this guy is basically now he has a normal heart function, right? So this is purely pharmacological, no plumbing, no electrical work involved, something that primary care physicians can do.
Can we stop treatment now that he is much better? Naveen.
Well, we can taper down the treatment, right? We can cut down on certain medications like probably Spironolactone and furosemide, but I wouldn't stop his Entresto, right? Because if you can see, this is a study that was published, and you can see that this was comparing to an ACE inhibitor, right? Yeah. And if you actually stop the medication, the ARNI, their LV function can again deteriorate. And there was another paper as well, right? So if you can see that the discontinuation of ARNI in patients with reduced EF leads to deterioration of the LV function as well as worsening of the functional class. Even if you stop them on Entresto and you start them back on ACE and ARB, the study showed that actually the LV function can reduce.
Okay, I have a confession just like Kanan. My patients are not that rich. So I always start with much ACE or ARB first. And with that, I get my desired result of improving LV and improving blood pressure. I'm quite happy. And I think even in these CPG that they showed, that Dato' Bala showed, it's only if the patient still remains symptomatic and LVF is less than 40, you may consider switching to ARNI.
with this hypertensive heart disease, can we just use our sponsor's drug, just use amlodipine, bring down blood pressure, and we still get paid for lunch,
The only thing is that this chap has got an LVEF of 30%. So for that reason, maybe later, that one don't know lah. Wait for you to do the trial. Okay, so yes, your take-home message.
Okay, so my take-home message is basically the importance of treating hypertension early. So in your clinical care or primary care setting, you'll be able to see these patients and start them on treatment early, even before getting them referred to a cardiologist, educating patients on home monitoring and compliance to therapy. For example, this man, he was started on ARB by the GP, but again, he did not start it until he came back to see me. And then we spoke about the role of ARNIs, SJLTs, and the importance of continuation of therapy in cases of heart failure. And my final take-home message is, paying heed to your wife's nagging may actually save your life.
Thank you. Thank you very much.
Thanks.
So yes, there are 4 pillars, but when the patient's symptoms improve, you can actually down titrate the diuretics, the spiral, and the others would depend upon the patient's condition. The other case is by Dr. Choi. It's a rather interesting case. I think another case of breathlessness.
So let me entice you with a fairly recent case of mine. I have to admit that sometimes, in the clinic, after long hours of talking, one may get a bit biased. So I have a patient here, 42-year-old female, absolutely no risk factors, no family risk factor as well. Fit, as you can see, fitness trainer. I mean, if you're not fit, it's very hard to be a fitness trainer. So in order to make other people fit, she has to be fit. So it means that you ask the person to run 20 minutes, you should be able to run at least 30. So that's the definition of a fitness trainer. She doesn't smoke nor drink. She came to me with a very clear-cut history of being breathless for the past 1 week. And she noticed it during work, obviously, because she's a fitness trainer. And interestingly, she almost fainted once, she said, while doing her job. So, of course, being very biased, sometimes I say, you're young, your BP must be low. I think it's probably just one of those vagal events, So maybe nothing too much to worry about. Because I rely a lot on pre-test probability. And her pre-test probability is like really rock bottom. So anyway, back to the story. She's about 64 kilo, 170 in height. BP, as you can see, is a bit on the lower side. Not surprising for a fairly fit person. Pulse 80, all right, regular and strong. Oxygen saturation 97. So I'm not too sure how many of you feel that 97 under room air is normal, or you think it's subnormal. Okay, so some say subnormal, but I can tell you it's actually normal for some people, because myself is only 96. Anyway, clinically, nothing, no murmur. Look at the JVP really hard until she got a bit worried. Nothing elevated, no edema. Distally, as always, the pulses are strong. So at this point, what would you do, Dr. Naveen, if you were to be in the same position in the clinic?
Her main presenting complaint is shortness of breath. So I'll do a simple chest X-ray and probably an ECG as well.
I totally agree. So indeed, we got her a chest X-ray. This is her chest X-ray. And I copied the exact report, which is NAD, NAD, NAD. Everything is normal according to the radiologist, which I totally agree. And we also talk about ECG. So I did an ECG for her. Dr. Jaya, do you want to?
Yeah, some non-specific T-wave inversions in 3 and AVF, but yes, I also would have passed this off as completely normal.
Correct. So again,
I mean, there's a partial right bundle branch block in V1, but we often see this in young women, so no big deal.
Correct. So I mean, if we really want to stretch it, then like what Dr. Jaya said, a bit of partial RBBB, and maybe the axis seem to be a bit rotated to the right. But remember, she's a fit lady, so sometimes the heart is not entirely back to the, not entirely so-called normal axis. So it may not be something pathological. But other causes of so-called abnormal ECG will be like at the back of your mind, something to do with the lungs, something to do with the some ASD, for example. So we did an echo, and this is still image, but one look on these 4 still images, maybe I can get Dr. Yap to comment on the echo.
So normally on the echo, this on the left is the 4-chamber view. So on the 4-chamber view, this part is your left ventricle, left atrium, right ventricle, and right atrium. On the cross-sectional view, the short axis, you will see that this is the left ventricle and this is the right ventricle. So this is a still picture, but I think we've been told the LV function is normal, right? We're looking at the size of the left ventricle compared to the right ventricle. I'm not sure whether you can appreciate the right ventricle looks a little bit bigger than the left, I think. Normally it should be the other way around. And similarly on here, maybe. But these are quite subtle, not easy to see.
Yes, I agree. And initially, the report seemed to be, reported to be normal. This picture seems to show the RA and RV a bit enlarged in size. But the short axis tells us that the pressure in the right ventricle is normal. Why is this important? Because sometimes in massive pulmonary embolism, if you were to do an echo bedside, if you see the RV being big enough and high pressure enough, it may push onto the septum and you get like a D shape on the left ventricle, which we do not see in this patient. So anyway, let's just say it's normal LVEF, everything is normal, and there's no ASD, like how I mentioned earlier. So we did some blood tests as well. She's not anemic. She has no sign of infection. Thyroid is normal. Pro-BNP is only 16 and troponin T is only 3.8. I even asked her to run on the treadmill. I said, you're a cross trainer, right? So why don't you just run on the treadmill and see? And she completed the whole stress test with very good target heart rate, no ST changes, nothing at all. So I'm stuck. So what do we do next? So I went back, good old classical history taking. So I sat her down and said, look, this is something very unusual. I can't seem to find anything wrong with you. And is there anything that you didn't tell me? And she said, I don't think it's relevant, but I've been going for acupuncture, and I'm actually a believer of acupuncture myself. But this session seemed to be a little bit different because after coming back from the acupuncture session, I had very bad buttock and thigh pain on my left side, she said. And shortly after that, she developed shortness of breath. So I examined her immediately. It's more like a retrospective thing. I pitch it here, pitch it there. Nope, no calf tenderness. All the joints seem to be fine. But having that part of the history, I put her back to some kind of investigation. So I sent her down for a Doppler of the lower limb. If I can get Dr. Koh to comment.
These are still images.
Yeah.
Okay, so if you look at the ultrasound, the one that is dark color is the vein. So sometimes when you compress the vein with ultrasound, you want it to get compressed because the vein is very compressible. So you can even see that there's a thrombus there to begin with already.
Yep.
And then you can't even compress the vein. So most likely, you know that you are dealing with some thrombus is there.
Yep. So by comparison, if you look on your left, it's actually the right popliteal vein, and it's round. And when you compress, it's compressible. On the other hand, on the right side, you can see a very big glaring thrombus. It's even printed in bold, thrombus there. So this patient has a DVT, even at the point of examination. And given the clinical picture of shortness of breath, recent acupuncture, and ongoing DVT, I guess it makes sense to send her for more tests, even though she's so young. So we did a CT pulmonary angiogram, and you can see, sorry for the poor resolution, but you can see thrombus everywhere. On the right side of the pulmonary artery, left side of the pulmonary artery, but she's lucky because it's not a saddle embolism, it's quite small. And this is the actual report, bilateral pulmonary embolism. At this point, no pulmonary infarction or whatsoever yet. So rightfully, this is a diagnosis of a pulmonary embolism in a fairly asymptomatic, a fairly healthy patient who comes in with a very clear-cut history of shortness of breath. And despite all the basic tests we have done, which I admit probably on the hindsight would have picked up a bit of a right axis deviation, and like what Dr. Yap said, with a bit of a right ventricular dilatation, you know. So because I was a bit biased, so I did not think that much lah. So at this moment, at this point of diagnosis, how do we treat the pulmonary embolism? Datuk Bala, maybe?
First of all, I congratulate you for this diagnosis. It's quite a difficult diagnosis, actually.
Yeah.
How it was picked up and how it went on. So after this, the main issue here is we have to discuss with the patient the etiology and what is the medication for her. But there's multiple foci of embolus in the lungs. So I would fairly refer her to a vascular surgeon and decide on further whether he needs an embolectomy or just medication. There are NOAC agents which can be used for this.
Correct. So I totally agree. So we are at a juncture whether we want to push the patient towards something more invasive, like going in and sucking out the clots, or should we just treat her medically with anticoagulation? And also on top of that, we have to investigate why is she developing all these clots. Is it because of the acupuncture that she had, or is it something of a primary cause? Well, because she was quite stable, she actually, her vitals are all right, her saturation is okay, she has no sign of RV dilatation. So I thought that at that point I treated her medically. I gave her anticoagulation. I also got my colleague in, hematology referral, to make sure she does not have a primary cause of thrombosis. And she made a very good recovery. But a very interesting point, because there are patients who actually need intervention, who actually need to go in and fish out. I was just having a discussion with Dr. Nazrul earlier as well, whether there's a role in doing early intervention in preventing something more chronic, like a CTEPH, chronic pulmonary embolism disorder, where you can actually have pulmonary hypertension at the end. So that maybe we can discuss later. But for my case, I treated her with a good old anticoagulation therapy, and I just saw her, I think, a couple of weeks ago. She resumed back her job, and she's fitter than ever, she said. Yeah, so learning points, some pulmonary embolism can be quite subtle in my case. Retrospective points will be the ECG apparently is not that normal after all, and my normal echo was actually not that normal after all, a little bit. But I think the most important thing is actually to always take a good history. When the patient says she's fine, always assume that she's not fine. If you're unsure, always ask again. Yeah, so that's my case.
I think in the interest of time, we will just look at some of the questions that was asked. One of the questions is, patients with a history of heart failure started with bisoprolol 2.5, since then complaints of erectile dysfunction. How, in these patients, how would we manage, since beta blocker is one of the side effects and patients still concerned about his sexual life? Yep, would you like to take the question? That means you are giving him beta blockers and he is having sexual dysfunction, and you need beta blockers, like you said, is one of the pillars of therapy.
Yeah, I've had quite a few patients mention the possibility of beta blockers causing sexual dysfunction in men. I'm not sure in those cases whether it's definite. I mean, we don't know for sure. Certainly in the literature, there is a slight implication of that possibility. But in most cases, the reason for the sexual dysfunction is actually the underlying disease. So for example, a lot of them could be diabetic, they have small vessel disease, and this can lead to sexual dysfunction. And also, commonly in ischemic heart disease, the patients also have associated sexual dysfunction. So normally what I would do is go through all this with the patient and explain the science behind it, etc. At the end of the day, it's very difficult to tell. But when the patients have quite a clear fixation that such a thing is already causing them something, an experience which is very unpleasant, I would probably withhold the beta blocker and use the other means for heart failure therapy.
So yes, the cause may be multifactorial, but one of the things you could use nebivolol as instead of bisoprolol, which supposedly causes less sexual dysfunction. There's a question, is Entresto a must or can we use a combination of other medications for heart failure, I guess? I guess it's a RAS blocker, as we mentioned earlier. We can start with ACE-ARB and switch to Entresto if the patient remains symptomatic or his LV function is not good. Do you consider, okay, now this is for Navin's patient. Do you consider this young male patient as a young hypertensive? And any specific investigation was done to rule out a secondary cause? And the second part was, why was a beta blocker used as antihypertensive?
Well, I mean, at the point of diagnosis, which was 4 years ago, he was about 40 years old. So you can actually consider him a young hypertensive, but he did have a very strong family history of hypertension. And at that point in time, he already had presented with all the end organ complications, so I opted to treat him. And maybe if he was not responding to treatment, I would have considered doing something to investigate. And I think the investigations that need to be done for this group of patients is fairly extensive, secondary causes, hormonal or vascular issues, right? As for the beta blocker, as we mentioned earlier, it's one of the 4 pillars of medications for anti-failure. So that's the reason I started him on that. And also, I mean, I was joking about the part where his wife was there and his heart rate was 100. So I think he was a bit tachycardic as well. So that's the other reason why I started him on Concor.
So it was basically not as a pure antihypertensive, but for anti-failure and
Yes.
for other reasons. Okay, there's a lot of questions about this lady of choice. Is she on oral contraceptive pills? Yes or no? Was your patient on an oral contraceptive which could have predisposed? No. And how can acupuncture cause the DVT?
Okay, very good question. I actually asked one of my good friends, and his dad actually does acupuncture. And he told me the one reason why this could have led to DVT is because the point was not correct. So in acupuncture, you're supposed to there's some points, they call it some meridian points. And usually you don't have vessels at this point. So probably, I assume, probably the person who did it, due to variation, I think, must have hit one of the veins. And maybe that predisposed to thrombogenicity.
Okay, another question for you. Is the trained, I mean, she is so fit, but her heart rate was 80, I think. So that itself was like a red flag.
Yes, on the hindsight, retrospectively, yes. But I also have to admit that bradycardia in athletic, right? I think it's more prevalent in male compared to I'm not sure. You know, if you have a very fit woman, she might not be as brady as a very fit man. I'm not too sure whether this is just my own observation.
Your own observation. Ko, what do you think?
I mean, if any lady that sees Choi, the heart rate will elevate about 30 beats per minute. So I wouldn't take that as a significant value.
Okay, and then what anticoagulants, what antithrombotic were given for her, and how duration of treatment? Is it lifelong?
Yep, very good question. So I started her with a very standard anticoagulation therapy, which is enoxaparin, BD, according to her weight, for days. At the same time, the hematologist came in and the doctor actually put her on Xarelto, rivaroxaban. The duration at this point is still about, I think, 3 to 6 months. There are some tests were not back yet. I guess if they say the patient also has primary thrombogenicity, she may actually need it for life. But so far, I think the tests are all negative. So this is a provoked type of thromboembolic event. So in the provoked case, I think there is a duration that we observe, and the patient usually don't take it for life.
Okay, so the last question, I think, for interest of time, is to Dr. Koh. Ablation therapy for paroxysmal VT, is it permanent? And radiofrequency ablation, is it done under GA?
Most of the ventricular tachycardia, like I showed earlier, idiopathic means that is not related to scar. So they are normal structural heart. So yes, the radiofrequency ablation are actually permanent curative treatment in most of the patients. Some may recur. If they recur in a manner that is troubling the patient or causing problems like earlier, heart failure, all these things, we can always go in again and re-ablate again. And the second ablation usually are more successful. So, yes, another, what was the other
Is
question?
it done under GA?
No, most of the idiopathic ventricular tachycardia ablation done only under, actually not even sedation, local anesthesia. So a bit of sedation if the patient is too anxious.
Let me just ask one last question to you, Cole.
Yes.
Now, do you think your SVT ablation was the cause for her subsequent VT? Was it because you caused the scar there, right? Was that the source?
Oh, definitely not. The Holter shown actually is before the ablation. You can see the SVT was there. And then there's already a PVC to begin with. During the SVT ablation, we never went into the ventricle at all. It's actually at the AV node. It's a slow pathway ablation. And during that time also, I noticed PVC. But because the underlying presenting complaint at that time was SVT, keep on having SVT. So we treat the underlying cause. But it goes to show a lot of PVCs are, I mean, not a lot. Some PVC are really not benign. They progress. And we know that because me and Choi are always at the receiving end, and we see a lot of these cases in our site.
I asked the last question to Dr. Liu, actually. Now, what about this DVT and PE? Is it related? And what is the relationship with COVID infection and vaccinations?
Just to tell the audience here, after this COVID infection, the incidence of DVT and PE has actually increased, and we see lots of them. And I'm really interested in Choi's case. I do not think so the acupuncture is the cause. Maybe because if you were to poke into the vein repeatedly, there will be a focus there, and on the ultrasound you can actually pick up. For this lady, I would actually do a venogram and repeat a duplex scan to see whether there's any focus or whether that corresponds to the point where the needle goes into the leg. And the other issue is, I think you treated this patient correctly, because with a patient with pulmonary embolism, our pulmonary artery is actually a big system where there's a lot of thrombolytics there. If you were to repeat the CT scan, all the thrombus would have disappeared and lung would have come back to normal. So there's actually no indication for any thrombolysis or or catheter-directed thrombectomy. I think you might even make her worse. So I think what you did is correct. Yeah.